I'm joined now by the Nobel Prize winning immunologist, Professor Peter Doherty. Thanks for joining us, Professor. Firstly, I want to ask you about your observations of what we're seeing in the infection numbers in this country. We talk about flattening the curve, reducing the growth in the number of new infections. Do you see anything in the data and in our responses so far to give us hope that we're getting on top of this pandemic?
Yeah, Chris, it's still going up pretty fast, as what you'd expect. The controls have only been put in place for a relatively short time. But you also need to be a bit careful in looking at the data, because a lot of the case definition has been based on testing, and we've changed the rules for who can access testing. So it's going to be a bit unreliable in a sense, because we're changing the baseline. It's not a constant one. The real measure of this, of course, is going to be how successful we are, is what our hospital admissions will be as time goes by. But I hope that within a couple of weeks we'll start to see the curve flattening down. We have to do that, or we're going to get in a bad situation and we could start to look like Italy or Spain. So basically, I think the message the Prime Minister and the Premiers are putting out there is pretty strong, and we need people to comply. And still, there are situations where we're not getting really good compliance, from what I can see.
Professor, you literally wrote the book on pandemics, so of course they're not new, so we've learned a lot from history, but modern population density and modern mobility must make them a hell of a challenge now in this environment, something that this is demonstrating, but we're going to have to get used to permanently, aren't we?
Yeah, I've been banging on about this for years, and I did write a book about it back in 2012, I think it was, 2012, called Pandemics, What Everyone Needs to Know, which is a question and answer book. And so it's sort of pandemics for all of us. I think it's still pretty reasonable, but of course it doesn't cover more recent pandemics. Most of us in the influenza field, I've worked a lot with influenza. I'm an immunologist who works on virus infections, and most of us have been talking about the 1918 flu pandemic forever. Now, 1918, we had this terrible pandemic that started in Europe. It didn't get here until 1919 because it had to come by ship. And now, of course, any pandemic virus gets here very quickly by plane, and all of us are exposed. It's very hard to keep these things out. It'll be interesting to see what happens in New Zealand. They've shut down. It's a small island, single government administration. We'll see whether they can hold it by closing the country down.
Now, we've seen a reduction, at least in New South Wales, of new infections from today compared to the day before. We wouldn't want to jump to any conclusions from that. But of your assessment of the measures that have been put in place already, is it time to shut down, particularly New South Wales and Victoria, more stridently now, more strongly now, or should we be giving it a week or so to see how well the current measures play out?
Not really my field, Chris. I'm a lab guy, worked on mice for years, and now we do a lot with people, of course. What's happening is some of our people from the Institute in Melbourne are advising the Chief Medical Officer. They're epidemiologists. These are people who study virus spread, and we've also got public health people who are advising government. And it's really their call, not mine. And what we're seeing coming out from Prime Minister Scott Morrison and our premiers in New South Wales and Victoria, for instance, really reflects that advice. Now, some of the premiers are getting ahead of the Prime Minister. What I would say, though, is if we all observed what's coming from Canberra and what's coming from our state premiers, we have a good chance of shutting it down. They will ramp that up as they see the necessity, but I don't really have the expertise to comment on that with any detail.
No, I understand, and I apologise if I'm going over some ground that you covered in your first answer, because I lost audio for a while. I believe our audience heard you, but I missed some of what you had to say. But you're saying if we do adopt the measures that are in place now with social distancing and hygiene and the restrictions on travel, there's a good chance that in Australia we can, as you say, flatten the curve?
I think so, Chris, and don't apologise for anything. Basically,
I think that what Scott Morrison put out there is pretty clear. I think what we're getting from our Premier, Daniel Andrews, is very clear. I haven't been watching Gladys Berejiklian because it's not directly relevant to me. Basically, of course, when it comes to these restrictions on movement and so forth, we all live in states. The police are state-based and so forth, so we should be listening to both political arms. We are a federation and we don't always do things exactly the same time and exactly the same way. We're not China, obviously.
Now, you refer to yourself rather modestly as a lab guy. I know that's factual, but I mean, I think most lab guys would like to share a Nobel Prize at some stage. Just on that side of it, though, could you tell us about the role for antiviral drugs here and for a vaccine, the different roles for both those approaches and the time frames we should be expecting to get both of those advances in play?
Yeah, they're good questions. Antiviral drugs were emerging in the Wuhan outbreak, and the thrust has been to sort of get some good basic trials done to make sure they're effective. You can often go ahead with drugs if you don't know that they are effective, and actually you waste time and money and it doesn't work. So there are trial results, I believe, for some of the drugs. There was an anti-Ebola drug that looked promising. Hydrochloroquine that's been used in malaria has also had some promise. And there are also some other therapies for people with bad disease. We think in this disease there may be an element of what we call cytokine storm. These are molecules that are pushed out normally very early by the immune response before we turn on the specific immune response, what we call adaptive immunity. But sometimes as the infection goes on, and we may be seeing that here, part of the severe disease could be due to that non-specific immune response overreacting. So there are some therapies that are being tried with monoclonal antibodies, the same sort of treatments we use to switch on these to combat cancer. In fact, they're sort of protein products, but they're against molecules with names like interleukin-6 and interleukin-1 and tumor necrosis factor. Now, some people who are on treatment for, say, autoimmune diseases like rheumatoid arthritis will be familiar with some of these because they may be treated with them. But it could be that they won't stop the infection in any sense, like an antiviral drug might slow the infection early on if we're targeting the virus. But by targeting elements of the host response, we may make it much less severe. And of course, with a pneumonia like this, the problem is when the lungs clog up and you can no longer get enough oxygen, and that's you don't survive if you can't get enough oxygen. So if we can stop that lung clog up by turning back the dial a little bit, we might get a lot of more people through this.
And those advances could happen a lot more quickly than a vaccine, which might take at least a year?
I think we'll have reasonable clarity on a number of those things within a couple of months, 3 months or so forth. Maybe not from trials done here, though we have trials underway and proposed and in design, but from trials done, say, in China or one of the epicenters where there's been a big number of cases. China's ahead of us on this because they started to experience it first, and they've got pretty good science, and they've been looking into some of these things. So I think we might have some of those out there quicker. And of course, with therapies, you're using them in a situation where the person is already sick. So you can be a bit more adventurous with therapeutic intervention, especially if you think somebody's very sick and they may die. I mean, you can go ahead with almost an experimental approach because
it's worth the risk.
You can't do any harm. But with a vaccine, of course, you're going to give it to a lot of normal people. So you've got to be very, very careful with vaccines, read safety and efficacy, and that's really what's going to take the time. We've got the basic products made already. We've got a University of Queensland vaccine developed by Paul Young at UQ. It's been having funding from an international agency for 2 years before this. It's basically what we call a platform. You can slot things into it. Once they got the genetic sequence of the major proteins on COVID-19 that they need to tackle, then they slotted it in, and we've got that product. That product's already going into mice. CSIRO's involved. They're growing the stuff up. We're involved. We're helping with the lab tests and all the rest of it. So we're already on the line, but we have to go through that human safety and efficacy testing.
Just finally, Professor, there is data coming out from instances like the Diamond Princess, where they had a good, I suppose, test sample of people on board that ship, also from northern Italy and elsewhere, that suggests the number of COVID-19 infections is much higher than people realise, that because so many people apparently have been infected with the virus and shown no symptoms. Now, is this something that we should be worried about, or is this reassuring that people might be actually contracting the virus, perhaps developing an immunity and not suffering any symptoms?
Sure, Chris, it's reassuring. It's great. And in fact, it's making me feel better about it. Initially, what we were hearing out of Wuhan was a 2.5% death rate. Now, to put that in perspective, the death rate for seasonal influenza is 0.1%. And people die from influenza. 40,000 Americans die every year from the flu. But the 2.5% is 25 times as many. So that was really concerning. And 14% or so of people in my age group were conking out as well. So I was a bit worried about that one. Now, the Chinese, as they've gone ahead and done more testing and realising there's a lot of background infection that's pretty asymptomatic, and in fact we think 80% of people are going to have an asymptomatic or relatively mild infection and they'll be fine. And that's more younger people. The older people are more at risk. But as they've done more testing, now they've reduced their estimate of death rate down to about 1.4%. And for people over 60, it's about 2.6%. So those figures are going down. So that's really good. There's been a limitation on the testing.
Yep.
All the testing that's been done so far is for the presence of the virus. That means we have an active infection. And so, but the way you'd normally test for the prevalence of a disease is you'd test antibodies. That is, when we get the infection, we get an antibody response, and then the antibodies stick around in the blood,
Yep.
and we measure the antibody. So that's what we need to be measuring, but we don't have a rapid screening test out there yet. We have tests, but they're not suitable for rapid screening. So time to go.
We'll wait on that development. But fascinating stuff, Professor. Thanks so much for joining us.
Pleasure. Anytime.